So I'm going to not use my PowerPoint from Saturday and just talk about the concepts. Right? Yeah, it was. How's that for volume? Is that better? Okay. Yeah. No point in me talking to myself. So my topic on Saturday were brain malignancies, and we focus mostly on glioblastoma, which of course is a spectrum as well. And I think the first thing that I would say is after about 25 years of dealing with glioblastomas and certainly lots of other cancers, and punctuating sort of the middle of that time period with being involved in cancer research involving natural therapies, et cetera, that I really, I feel like after a few decades, you don't really have answers, but you have observations. And rather than knowing things that for sure work, what we do is try and learn from our mistakes. And so, while I would say, 20 years ago we could help GBM patients, for example, live longer and often slow their cancer down, et cetera, what we did then was very different from how things have evolved in those decades. And if you were here Saturday, I really broke down the way that we would approach things into three categories, three what I feel are very important categories. So the first, and if you saw my slide, it's the first and the last thing, is the diet and how somebody eats. The middle part was the metabolic support, and I'll expand on that, but that's essentially knowing that certainly any cancer cell, but especially the glioblastoma cell lines, are set up very differently, which is what makes them a malignancy, but they're set up biochemically very differently. And the things that make them able to grow and create trouble are also their weaknesses. So by trying to do metabolic therapies, we're trying to attack them at their weak points. And the nice thing is when you attack them at their weak points, it doesn't hurt your normal cells, which is one of the biggest problems with a lot of cancer therapies. Is if they're global and let's say they're cytotoxic, they affect all of the cells in a cytotoxic manner. So we'll kind of circle back to that. So we got diet, we have the metabolic type therapies, and then the third pillar, if you will, in my experience over all these years is really what we call the mind game, or your mind, where it is, how you're thinking, and what sort of not just thoughts that you're having, but also the thought environment around you. And that really comes from the observation over the years that you can have a cancer patient who's really trying and doing the best that they can, and if they live in a mentally, emotionally poisoned environment, they will often not survive as well as people who aren't. Now, if you take those three areas, being what and how we eat, what and how we manipulate the metabolism of both the normal cells and the tumor cells, and then the mysterious part that we call our mind and our thoughts, but also the people around us contributing to our mind and our thoughts, you have three really broad areas. And there are other areas, certainly, there's other things that are necessary, but these have been the areas that I have found if we focus down on and we do as much work as we can in those areas, that's when we have the best outcomes. And so in the evolution of looking at dietary therapies, especially with brain tumors, but really with many, many other cancers as well, I think that the first thing that we see with folks is we take a step back and look at, before we look at their macronutrients and all of that business, we take a step back and look at how clean what they're taking in is, okay? Because there's no point in setting up different macronutrient approaches, et cetera, if they're dragging toxins into the person's body constantly. We get enough toxins in the modern world just by living and breathing and be alive every day without eating them and forcing them into the system. So clean is the first goal. Now, if you look at the research that's specific to, say, the glioblastoma family, the dietary approach that takes the best advantage of the glioblastoma in a way that is good for the normal brain cell and bad for the glioma cell is either a ketogenic or a ketogenic adapted, say, low carbohydrate type diet. And that's for many, many reasons. There's people, we often think of it as, well, then that's a low sugar diet, so it's sort of starving the cancer of sugar, and that's one little piece of it. But what that leads to is a whole bunch of other switching that goes on in the metabolism. And a refrain, if you were there on Saturday when I was speaking, that I kept coming back to is the whole goal is to take advantage of this huge difference in metabolism between a glioblastoma cell and a normal brain cell. And if we can do things that are very happy for the normal brain cells, but force the glioblastoma cell into a metabolic situation that weakens it, it is more likely to undergo apoptosis. It is more likely to draw the attention of the immune system. It's more likely to stop growing so quickly. So that's really the bottom line when it comes to the dietary sort of interventions. Now, there's other things that can be done to get at this in a different way. Of course, whatever diet a person chooses, it needs to be clean, meaning as organic as is possible, humanly possible, as far as what you eat and drink. But the other thing that it's been around forever, actually, and humans used to do it commonly, but we haven't for the last probably century. But now there's a lot of research going on about it, and that's just intermittent fasting and resetting your metabolism. And there are data, coming out about people surviving with, say, breast cancer, 30% longer survival just if they do daily intermittent fasting, which is not that hard to pull off. It's it's somewhere around 12 to 16 hours on the low end. Some people do a little bit more. Some people will also do a different version of that where they'll do weekly fasting. And so they'll do a 24, 36 hour period once a week. But what it appears to us in looking at the way that this changes your chemistry is if you do it every day, there's literally just a reset period for a lot of the chemistry that, again, is not friendly to the glioma and is just fine for the rest of the body. So those are just some global ideas. Now, when it comes to the metabolic support, for those who were here Saturday, or if you saw the outline that we had printed that was floating around, I specifically, because I felt that this was a forum for people, more patients really than other doctors, et cetera, I specifically listed agents and supplements and things of that nature that everybody can get, as opposed to things that we might do in our clinic that are prescription items or require some sort of interventional therapy. So if you look through that and you thought, well, is that as strong as the therapies get? Well, for all intents and purposes, what was on that list is fairly strong if you actually do it. In the clinic, what we do is often add on to that other therapies that are hard to do at home, such as we have intravenous versions of metabolic therapies that we'll do very specifically on the front end to try and get things under control. We'll do, as was mentioned earlier, we'll do things like DMSO as an additive therapy. We'll do oxidative therapies. We'll do other agents such as dichloroacetate, which especially with brain tumors is very helpful. We'll also do immunologic therapies. Things like mistletoe is a very common one that we will do. And hyperthermia, again, we talked about heat just a little bit ago. Heat's one of the oldest therapeutic tools, and it's still, the longer we study it, the more amazing it gets. But in the metabolic support, I tried to list sort of and it wasn't making one more than the other, but there's the primary metabolic supports which are designed to take advantage of the weak biochemistry of a cancer cell, especially a glioma cell, and to force it to do a different type of metabolism. So if you were there and you saw, like every lecture uses this same picture, there's a normal cell on one side and a cancer cell on the other. And the normal cell is supposed to use an oxidative metabolism, takes the glucose in and burns it up in the mitochondria. Many cancer cells, especially the glioblastomas, get down to the point of the mitochondria and then they convert it to lactate. So they have a completely different metabolism. The mitochondria are very slow and weak. And what happens is that when they do this and they're exporting all of that lactate, they change the pH, they change the environment that they're in, and that change actually triggers more growth. It's one of the reasons especially brain tumors in the glioblastoma family are so quick to grow. Now, there's a number of things about that. One is that the dietary change helps to switch that. But then our primary therapies, and again, if it was an inpatient in our clinic, we'd be adding other things to it. But we looked at a couple of primary therapies. One that we've used more and more over the last decade is called poly-MVA, and that one goes right to the mitochondria and forces it to work harder and faster. And so if it's your mitochondria that's a normal cell, it's not a big deal. If you're a glioblastoma cell, that's a weakening of your metabolism. The next is oxaloacetate. Oxaloacetate is a part of the normal TCA, the Krebs cycle. It's a very interesting molecule, but the bottom line of what it does is it helps to remove glutamic acid from the nervous system. Really, it removes it from the whole body. The reason that's such a big deal is, especially in the glioblastoma, but really any tumor cell, part of this change in the chemistry around a tumor cell, when there's all this lactate being effluxed out there, is that they also pump out glutamate. Glutamate is one of the primary chemicals that you find rising in any neurodegenerative disorder. So if you have Parkinson's or MS or something like that, your glutamate levels are high in your brain. Well, if you have a brain tumor, your glutamate levels are very, very high as well. And the one universal thing that we know is that inflammatory mediators come back around and they trigger more cancer activity and growth. And so when we can remove inflammatory mediators such as glutamate, that becomes very helpful. And there's some really good animal model studies with oxaloacetate lowering glutamate and slowing or stopping cancer. So that's why that's one of our core things. The other is, and I kept this to a supplement so it was easy to get, was berberine. And berberine does a number of things. And just to shorten the story, what berberine really does is it's similar but not the same. You've probably read or heard about people using the diabetes medication metformin in cancer. Well, there's a lot of reasons why that may work, but what berberine does is it goes in and on the cell level, especially at the receptor sites, it helps the metabolic switching. And if you go back in my slides, you'll see there's a very pretty one with lots and lots of little markers on the cell that get switched with diet changes, etc. It basically goes and sensitizes those so that the dietary change and the other stuff you're doing work better. So it's a synergist.
How do you spell berberine?
B-E-R-B-E-R-I-N-E. Mm-hmm. Yeah, it's a constituent of things like blueberries and Oregon grape and stuff like that.
As long as you're spelling things, how do you spell that other word, oxy?
Oh, it's, yeah, okay. O-X-A-L-O-A-C-E-T-A-T-E.
You repeat that one more time.
Yes. O-X-A-L-O-A-C-E-T-A-T-E. It's like I'm at a spelling bee now. All right. I'll use them all in a sentence in a moment. Okay. But I want to get to time to questions. So the secondary group isn't really secondary. It's just all of these other things are nutrients that are known to either be deficient or improperly used in a glioblastoma cell line. And so the reason that we put them into people in a higher amount than we would normally see in some cases dietarily is that we're trying to saturate the nervous system tissues so that they have these nutrients, and when the nutrients are there, that the GBM cell doesn't know how to use, it again forces them into metabolism that is unfamiliar to them. And so those are 3 fat-soluble vitamins: vitamin D, vitamin K, and vitamin A. And if you look at the list, it's, vitamin K2 is usually what we use. Then CoQ10. And again, this is part of that mitochondrial weakness of a GBM cell. CoQ10 is heavily used in a couple places in mitochondria. So anything that you do that forces energy metabolism to go to the mitochondria is good for you and your good cells. It's very bad for tumor cells, especially GBMs. Then and there could be 100, but the 2 most common botanical things that we use, especially in central nervous system, are a combination of curcumin and boswellia. Boswellia is an Ayurvedic herb, normally thought of that way anyway, and it has a huge affinity for the central nervous system. But what we found is they appear to work better together as a team. Often we will have these patients do a ketone supplement, and if you look at the work of Dr. Thomas Seyfried or Dr. D'Agostino or Angela Poff, any of those guys, and they're talking about improving ketosis. And let's say you have a patient that just, dietarily they can't quite get there, you can still give them exogenous ketones that they're actually good for normal brain cells and toxic to the other cells. We also in our clinic use a lot of hyperbaric oxygen therapy, and that's an area that we do clinically, and have done that for a number of years. And there's a lot of reasons why that's useful and synergistic. But the bottom line is that it switches around a lot of the biochemistry that is pro-tumor and pushes it back towards the anti-tumor chemistry. And although the list could go on, the final botanical that we use quite a bit are cannabinoids. So the cannabis family, there's just a lot of different chemistry in cannabinoids. We've had legally the benefit in Washington of having medical cannabis use for at least close to 10 years at least. And so we've been able to do it with patients without getting arrested, essentially. And we've learned a lot, and as was mentioned earlier, it's those of us who used it for a long time, we're now seeing that there's higher doses appear to be anti-cancer as well. And I know in the beginning when we were using it in cancer research, we were using it all for side effects and quality of life things. So that's another exciting area. Now, people will say, well, do people do all of these things? Well, there's different levels of need. If you have somebody, what we always tell people is if you come in and you have a very active, rapid brain tumor, you don't want to wait, you don't want to delay anything. So you want to kind of do everything at once, move it forward. If you're on the other end of the spectrum and you've had regression of disease and things are calm, then there's more of a maintenance approach, which again would be dietary oriented, keeping things clean, all of that business. And then the third part that I mentioned, just like the diet has to be the beginning and the end. And I say that from, I said I have no answers, but I have a lot of experience and observations. In patients who won't do dietary changes, but they want to take pills and do all that stuff, they can sometimes get some traction. But if the diet really never changes, you're pushing a boulder uphill, and eventually it's going to roll over you. It's that way. Well, it's exactly the same, I believe, with the mental emotional part of the therapy. And the goal there with mental emotional being the third kind of pillar is to be very mindful of who is around you, of what they're saying, of what you're saying to yourself, of how you interact with your doctor. And we have a lot of patients who are seeing an oncologist, or maybe 2 or 3 of them. And one of the most important things, I think, if a patient's seeing an oncologist is, do they get along together? And what I will tell people is there's lots of oncologists, and if you don't resonate with that oncologist, and if you don't have a symbiotic relationship, even if you do or don't agree with what they're doing, if they as a human and you as a human don't relate well, get a different one. Because you don't, then that's for any of your, any healthcare providers. spouses, whatever. Sometimes you need a detox of people in your life. So that is also, I think, very important. So while there's much more that we could say, I think that the bottom line is the goal with all cancers, but especially brain tumors, because they can be so aggressive, and there's no good tumor that lives in your head, okay? That's the bottom line, is you want to take advantage of the tumor the best you can, and in all of the ways possible, not just one way. So we'll go to questions.
All right, just before we go to the question, I want to follow up on the comment you made about team of oncologists or several oncologists. You ask the patient, do they get along? And how do you resonate with the clinician, the oncologist? And that's something, when I'm talking to cancer patients all the time, which one is the best? Where would you go? Two things. Number one is, I don't have it, you have it. You're the one that's going.
Right.
You have to resonate.
Mm-hmm.
And I very often will tell people, if your doctor won't sit down and look you in the eye and put his hand on your shoulder,
mm-hmm.
go get another doctor.
Mm-hmm.
So with that, questions over here.
True.
Since you're focusing on the brain, I'm curious, do you do any neurotransmitter testing to balance the neurotransmitters?
Yeah, on a couple different levels. Usually in the beginning, we test other things because especially if it's a glioblastoma, things are moving so quickly, the neurotransmitter mix is going to change anyway with the therapy. We do look at inflammatory metabolites, et cetera. But later, if things have calmed down and let's say we've got either stable or regressing disease, then if the person is having leftover either mental emotional signs and symptoms or sleep issues or whatever, that's usually when we would check into those sorts of things. Yeah.
Okay, and secondly, the CBC, I'm concerned that, do you carte blanche give all patients vitamin K? Like, for example, what if the platelets were too high? You wouldn't want to give K.
Yeah. We do give all of them K2, but we use different doses, and at lower doses there are thresholds at which K2 is safe even with high platelet.
A number of doctors do use bioidentical hormones for treatment of various cancers, including breast cancer and prostate cancer. What is your take on that one?
We move way out of the brain. I think ultimately it depends on the cancer, the tumor type. I have seen recently, for example, studies coming out about, say, prostate cancer and testosterone actually as therapy instead of testosterone deprivation, and it actually is useful in some patients. Now, we haven't done that, but I'm starting to see that come out. We do, in many of them, use progesterone or pregnenolone with a lot because that's generally much safer. The only other thing, as I guess a universal thing in breast or prostate, would be the use of estrogens in breast cancer. We normally shy away from. So, yeah.
It seems that most ladies who have breast cancer of an older age bracket, very postmenopausal, they don't have much estrogen to begin with.
Mm-hmm.
Then you're using an estrogen blocking therapy. It may not be very good. And almost, if not 100% of every men who have prostate cancer, they don't have enough testosterone to begin with. And then comes the ablation, they don't want him to have any. And
Mm-hmm.
it has its side effects, not having those things.
Yeah, I would agree.
I just want to make a comment about the poly-MVA. I've been working with it for a really long time, And you had mentioned that the healthy cells didn't mind it. And I'm sure you know Dr. Frank Antonovich did the research in which he showed that if normal cells are low in oxygen, that poly-MVA makes them work better. And Dr. Antonovich did a really elegant study in which he proved that it worked better to protect against stroke damage 3 times better than anything he'd ever tested.
Yeah, yeah.
Archie, anything you want to add about DMSO and brain glioblastoma?
Okay, well, I'll just make a very brief. I found that the various clinics I've worked with, that DMSO with any of the brain tumors, it will help carry whatever you are using across the blood-brain barrier, and I think that probably DMSO. You mentioned you use some DMSO. And I think that it's very important to use the DMSO with any kind of a brain problem, especially the glioblastomas.
Yeah, we use in almost all of our brain tumors, especially in the IV center, we use IV DMSO with most all of them, unless there's some reason we can't. Yeah.
Are you aware of the treatment for GBM that's been approved by the FDA that uses cell phone-like radiation? It's a NovoCure. It's for recurrent GBM, and it's not going to regress the tumor, but it is extending life, according to the Society of Neuro-Oncology recent meetings. What I find interesting about that is that they're using a frequency that is similar to that of a cell phone because it's weakening the blood-brain barrier. So I would ask whether you and others here as clinicians are able now to give your patients advice about why and how not to put a frequency radiating microwave device next to the brain, particularly if they already have a diagnosis of GBM.
Yeah, and that kind of comes under our engineering controls discussion we have with patients around around disruptors. Just like, toxins in food, et cetera, and toxins are ubiquitous, and so even if you take them out of your food supply, we still get toxins passively. The same really happens with things like cell phones and other emitting devices, et cetera. We try to have patients get them as far away as possible and have none in their rooms and all of that. And when you have a brain tumor, your blood-brain barrier is already not correct, and that doesn't help. And so then if you're sitting there weakening it all the time, and what really worries me is, we have a whole generation of little children who are around devices constantly, and that I don't think that's going to end well. So yeah, I've seen that therapy. I've not actually had a patient come in who's using it, and it's